Good afternoon, ladies and gentlemen. Thank you very much for invitation. And first of all, I would like to thank the organizers for the opportunity to present the results of our study, which is dedicated to a new understanding of cell membrane damage and the stages of ischemia and reperfusion of liver grafts. So, as you know, during ischemia and reperfusion, the balance between the production and disposal of ROS is disrupted, which leads to oxidative stress. The interaction of ROS with cell membrane lipid, usually considered in the context of lipid peroxidation in the non-polar part of the cell membrane. The most commonly used assay for lipid peroxidation assessment are isoprostans, aldehydes, ketones, and others. The high reactivity and short lifetime of hydroxyl radicals are the determining factor that the damage will also occur in the polar part of the cell membrane in contact with aqueous phase. We found that activation of phospholipase A2 leads to transformation of phospholipid to lysophospholipid and changes the shape of the molecule from cylinder to inverted cone. This transformation causes a positive deformation of cell membrane and leads to further rupture. Further interaction with phospholipase A2 leads to fragmentation of polar head of lysophospholipid. The molecule further destroys homogeneously in two directions with different speed that leads to formation of two main products, palmitoxacetin and steroloxacetin. All process of this lysophospholipid fragmentation has been described in details in our previous paper that was published last year. But more interesting thing was previously discovered in vitro that all this process of fragmentation and of lysophospholipids can be suppressed by oxygen. And normoxia leads to modification of the molecular structure without its destruction. So the aim of the study was to evaluate the concentration of fragmentation products in liver transplant recipients and its correlation with the degree of ischemic-reperfusion injury depending on the liver preservation strategy. The study included 75 liver transplant recipients that were divided into two groups according to preservation method, with the median age of 55 years, a MELD score of 16, and they all received DBD liver grafts. All donors were in both groups standard and extended criteria, with the median age of 45 years and the median total ischemia time of 540 minutes. Machine perfusion was performed in hope mode for 2 hours at back to base with 2 liters of UW machine perfusion solution, and the blood samples and liver graft tissue samples were collected within 2 hours after portal reperfusion and during first 7 postoperative days. The fragmentation products were identified in the serum of liver transplant recipients and quantified using mass spectrometry method. And the allograft dysfunction was assessed during first 7 days according to Kim-Olhoff criteria. So the main indications for transplantation in this cohort of patients were viral cirrhosis, HCC, metabolic-associated liver disease. We had some cases of unresectable alveococcus, had 2 patients with Glaskin tumor, and 3 patients who underwent salvage liver transplantation for acute liver failure due to Amanita phalloides poisoning. So as the result of this study, we found that the level of oxidative stress markers were significantly lower in the group of patients who underwent machine perfusion compared to static cold storage. It was also found that the level of fragmentation products in the blood of patients 2 hours after reperfusion was significantly lower in the group where machine perfusion was performed, in contrast with static cold storage. We also discovered that the level of fragmentation products after 2 hours of reperfusion is in direct, strong correlation with degree of ischemic-reperfusion injury. It should be noted also that in this group of patients we had no primary non-function. Also, morphological analysis showed that minimal ischemic-reperfusion injury was more prevalent in the Hope group, while mild and moderate ischemic-reperfusion injury were detected with higher frequency among transplants that were preserved under static cold storage. Also, immunohistochemical analysis of biopsies showed that on the 7th post-operative day, AGF expression was significantly lower in Hope grafts compared to static cold storage group. So, in our opinion, it indicates less ischemic-reperfusion injury in this group. It is also confirmed by clinical results. We had early allograft dysfunction in the machine perfusion group was 2 times lower compared to static cold storage. So as a conclusion, I would like to say that development of ischemic-reperfusion injury leads to severe disruption of oxidative reductive homeostasis. The concentration of lysophospholipid fragmentation products in blood serum of liver transplant recipients can be used to assess ischemic-reperfusion injury of liver grafts and strongly associated with preservation method. The machine perfusion enables to reduce the degree of ischemic injury of liver graft and decreases the level of endogenous damaging factors. And this method of preservation is safe and effective for liver graft preservation, especially in extended criteria donors. Thank you.